So my name's Melissa. I am with the academic team um, at ADMI, which is Aspen Dental Management. The academic team is pretty much, we're the ones that kind of go out to the schools, the residency programs, and kind of play like the liaison between the residents and the students and Aspen Dental, just to let you guys know what opportunities are available for you when you complete school and residency, and just like, kind of let you know more about Aspen. I work specifically with specialty. So I work with oral surgeons and endodontists. So I see a lot of my OS residents and some people that I've hired recently on. So thank you guys for joining. Good to see you. ADMI is the support organization for Aspen. So in case you're not familiar with kind of how it's structured, the Aspen Dental clinical offices are owned by general dentists. And ADMI, again, is the support organization for those practices. So basically what we handle is everything that doesn't have to do with, clinically treating a patient in a chair. So like literally everything else from finding an office to, getting the equipment, the IT, payroll, benefits, staffing, marketing, insurances. We work with all the insurances. So kind of like all the back office stuff that keeps the business end of it running. And then the doctors are obviously the ones responsible for handling all the clinical stuff. What's nice about tonight is that we do have like a good mix of oral surgeons and general dentists on. And I really like that because it gives me an opportunity to kind of share with you guys how the general dentists and the oral surgeons work together in an office. So a little bit of my background, I come from Patterson, kind of like Henry Schein's biggest competitor. So I worked on the supply side, and the biggest thing that I would get from all of my specialists would be, the referral base has gone down. The GPs are trying to keep all their patients. They're not referring patients out to the specialists. And so that kind of relationship that they have is kind of dwindling a little bit. What I loved about Aspen and what drew me to this position was I felt like the relationship between the specialists that work in the office and the general practice owners is so great. Like they work seamlessly together. Because ultimately, if you're a specialist working in an office, you are an employee of that practice owner. And so, they get an incentive for the production that you're doing in their office. Obviously, it's their office, so they're getting a piece of it. You're getting a patient in your chair all day long, so you never have to worry about who's referring patients over to you and not being productive in your day as a specialist. And the general dentist kind of has more of an incentive to pass the patient on to you when it's applicable, because they can be seeing 4 other new patients in their chair while you're doing the work in the room next door. So that's kind of like my little backstory and why I think that, Aspen's such a great choice for GPs and, specifically for myself, oral surgeons. There is a question and answer kind of chat at the bottom if you guys see on your screen. So if you have any questions,
First question is it your swag so popping?
I mean, I
I'm
try,
feeling a little,
guys.
I'm feeling a little underdressed. I
try.
gotta admit, I'm a little underdressed tonight.
I think I could take a wild guess of who that was, but I'm not going to call you out on it. We'll talk later. But that's my spiel. That's my intro. I'm so happy to have you guys. Without further ado, I will pass this over to the person that you really want to hear from, Dr. Rawal. Take it away.
Well, thanks, Melissa. So welcome, everyone. My name's Dr. Sundeep Rawal, Senior Vice President of Implants here at Aspen Dental. My background is I'm actually a prosthodontist by training. I did my undergrad in dentistry at the University of Florida, and then I went out to California and did my prosthodontics at University of California, San Francisco, where I was lucky to be exposed to the latest and greatest in technology at the time, which was a little over a decade, almost a decade and a half ago. And I was able to come out and start a private practice. I was in the private practice world for over 10 years, where I had a multi-doctor, multi-location prosthodontic practice. And at the same time, I got into education, because what we're going to talk about tonight and what has been happening in the industry over the last 10 years, 15 years is really a renaissance of how we treat our patients today. And it really boils down to technology and the innovations that we have to allow us to offer care to our patients in predictable ways. And I was just lucky to be a right kid at the right place and got into technology and kind of rode that wave, got into education, was able to educate around the world for a lot of years, and ended up joining our wonderful Aspen Nation about a year and a half ago, and have been tasked with uh, running all things related to implant dentistry. And can you imagine what a great opportunity it is to be with a company like Aspen, with the team and the people around us, with the doctors, hopefully some of you in the future, and more importantly, to be in a part of dentistry that is exciting and vibrant and dynamic. And that's what implant dentistry is today because of technology. And what I really love about the ecosystem, and Melissa touched on it, is it really allows us to work as closely with the entire team, being your GPs, your oral surgeons, your staff, your auxiliary, your hygienist, your front, your dental assistant, to be able to offer care in ways we never thought possible, which is what I'm really here to talk to you about tonight, which is this concept of digitally driven dentistry. What I'm really excited to share with all of you today is everything you're going to see is what's occurring in our Aspen offices. And what's exciting to me is it's not stuff that, oh, it's coming in the pipeline. It's here today. What you see when we talk about digital workflows, diagnosing and treatment planning, executing on that plan, all of that comes down to things that we're currently able to do today, which is exciting to me because, you know, I'm able to highlight the most innovative ways we can treat patients today, and do it, you know, with the confidence of saying that this is how we practice. This is how our offices are structured to be able to offer care in that fashion. So, you know, when we talk about this, I know we've got a mixed group tonight. We've got some specialists, we've got some GPs, restorative dentists, and soon to be restorative dentists. I I'm really excited because everything that we're going to talk about is 100% applicable to any of you out there, whether your experience level is a lot or a little bit, whether you're placing implants today or going to be placing implants in the future, whether you've ever picked up an intraoral scanner or not, we are going to be able to kind of show you that it's all applicable to all of you today. So when we think about what we're really trying to achieve, we have a goal. You know, we have a goal in dentistry, and I always like to say that this is my goal in dentistry, but gone are the days of us looking at things in black and white. You know, there was a time in dentistry, especially in implant dentistry, where we would look at things in black and white. Mrs. Smith, you've got a missing tooth or missing teeth. It's a big black hole. We're going to replace it, and we're going to replace it with a bunch of white. And it doesn't really matter what that white looks like. Hey, it's the best we've got. But today we don't talk like that. Today, when we think about our goal, what we really talk about is black, white, and pink, or looking at things in color. And how do we recreate nature or the illusion of nature? How do we bring somebody back to that vision of health? Because my goal today is this: a patient who's happy and healthy. This patient loves her smile. You say smile, her whole face lights up. She goes to the restaurant. Well, she used to go to the restaurant and eat anything on the menu, right? Except for the last 10 months, right? She loves to go out and socialize. She has a full, vibrant life. She's got a job. She's got a family or a social life or dates. She, you know, she's somebody who is just loving her life and feels like she has the best version of herself. And she's got that with a happy, healthy dentition. The reality is, when we look at this, how do we get to this goal when a patient presents looking like this? All right. And this is a patient who we see frequently, especially for those of you that have, you know, you practiced a little bit, or, you know, those, when you guys soon to get out into practice, you're going to see this patient comes in. Chief comment is, Doc, I'm ready to go. I'm ready to restore. And I have to be honest, I wasn't part of this treatment plan. I got this patient, walked in my door and said, hey, I need teeth. And we went through the process of diagnosing and treatment planning what we could do for her. In this case, It's not a question of where the implants go. It's just a question of making some restorations. And when we went to do this, we always start in the maxillary aesthetic zone, in the smile line. We're always going to start in baby steps because, look, I think I'm an average dentist, but I'm not good enough to just make an impression, make 2 crowns, and nail it. No, it's going to look perfect on day 1. I've got to do this in baby steps. I'm going to make an impression. I'm going to provisionalize, sculpt the tissue, what we call site development, because I want to recreate nature, that illusion of a tooth erupting from the gingiva. And so when we do this, I make the impression, I start to notice a couple of things, right? Like incisal ledge, the screw trajectory is kind of facial towards the incisal ledge. And so now I'm thinking, okay, well, in my decision tree, maybe I'm gonna have to, cement retain these crowns, was the thought process 10 years ago when I did this case. But I always make my temporary screw retained because I want retrievability. I want to be able to site develop, add or subtract in the subcritical contour to be able to develop the emergence profile I want. And so we deliver 2 screw retained crowns. And the patient goes to me, "Doc, thank you. Thank you. I'm so happy. I'm so happy because I was wearing this flipper for 2 years and now I don't have to wear that anymore. Thank you. But Doc, I have a question. What are these 2 gray lines going down the middle of my teeth?" And I'm thinking, 2 gray lines? What is she talking about? And what she was referring to is the white material was so thin, she could see gray from the titanium temporary cylinders coming through. So now I'm thinking in my head, okay, maybe cement retained, and I better use white only materials. So I've just diagnosed and treatment planned 2 custom zirconia abutments with cement retained crowns. Now, guys, that's nothing new in dentistry. We've been doing that since the 90s. Okay, nothing new. Well, when you take a closer look, you can see a couple of things. Number one, if you look at our perio literature today, it supports the reality that the head of the implant should be placed ideally 3 millimeters apical to the proposed zenith, the highest point of the free gingival margin. Now, on a radiograph, we can't see a free gingival margin, so we have a rule of thumb, 3 to 4 millimeters apical to the adjacent CEJs. But when you look here, you see that these are actually slightly coronal to the adjacent CEJs. And these are 3.0 diameter dental implants, actually. And a fun fact about 3.0s, we do not make zirconia abutments for 3.0 diameter dental implants. Why? Because when we all love zirconia, you guys that are in dental school, biomaterials 101, right? We know that zirconia is a material that is tough under compression, performs very well under compressive force, but you put it under tension, off-axis loading, it's a ceramic. You take a china plate, you drop it on the ground, it's going to shatter. So if you make zirconia thin, because it's a narrow diameter dental implant, you put a hole through the middle of it for a screw and start banging on it sideways, function, it doesn't perform very well. And so it has a higher incidence of fracture. Therefore, we don't make zirconia abutments for 3.0 diameter implants. So now I'm scratching my head, like, what am I going to do in this case? And normally this is the time I would say, hey, what do you guys think? Give somebody shout out an answer. If somebody wants to type in an answer, what would you do? You need a white only abutment. You can't use zirconia. Somebody have an answer for me? What do you think? I'll give you like 15 seconds to answer in the chat. Any ideas?
I feel like we should have the Jeopardy music playing.
Yeah, I know. Call me Alex.
Right? Guys,
Okay.
crickets.
Well, I mean, it's a tough question. It really is, and I pose this question and it's always crickets because there's not a good solution. In the wonderful world of CAD CAM that we all live in today, that I've lived in for over 10, 15 years now, the only thing we could come up with was waxing and casting 2 UCLA style abutments with a high noble alloy, stacking porcelain to create a custom porcelain emergence, a custom porcelain shoulder margin, and opaque the whole thing in porcelain. Now, let me say that in English, okay? What I'm really saying is the cost of my normal abutments or crowns is right here. The 2 UCLA waxing sleeves, wax, invest, burnout, sling molten gold, platinum, palladium. Before you know it, these 2 abutments and crowns were the most expensive single tooth restorations I've made in the last 10 years. And I lost money on the case. And if that wasn't bad enough, here's the outcome. Now you look at this and you say, huh, something doesn't look right. Something doesn't look right. How many of you think that this is like front page banner of my website? Raise your hand if you think that. No hands, right? Why? Because it doesn't look right. One hand. Okay. The reality is this doesn't look aesthetically pleasing because the laterals are too short. Why did I make the laterals too short? Because that's where the implants were placed. They were too shallow. And today, in the world we live in implant dentistry, this is failure of therapy. Remember, therapy today is not titanium. It's not a screw that gets osseointegrated to bone. Therapy is diagnosis to delivery of teeth that look like teeth, feel like teeth, and function like teeth. And part of that success is looking like teeth. These don't look like teeth should. They look too short. And so we realize in my world, in my hands today, that this is a failure of therapy on day one. Now, mind you, 2 perfectly integrated implants will probably last the patient the rest of her life. 2 well-made crowns, got the white to look good. You know, it's a B1 or 3M1, whatever, it looks right. But this is a failure of therapy. And so how do we overcome these failures? How do we overcome that? And today it's through the use of digital technology to give us predictability when we diagnose, when we treatment plan, when we execute or operate to that plan, and then when we go through the definitive phase of treatment. And why I get so excited is because digital technology or the digital ecosystem or digital workflow or whatever you want to call it today, this has revolutionized dentistry. We are in the midst of a renaissance. How all of us practiced 5 years ago or 10 years ago is not how we practice today. What's really exciting for me is how you and I are practicing, how some of you are being trained today isn't what you're going to be doing in 2 years or 3 years or 5 years, because we're changing and evolving so fast because of the technology. And it really is so amazing to me because our paradigm here at Aspen is we want to be at the forefront of that wave. We want to be leading the charge, being able to innovate to offer our patients the best care in the best ways possible. And so when we think about that, where does that start? Well, it all starts with data acquisition. And today it starts with digital data acquisition. When you think about the workflows, you think about where we are today, it's going to start with optical impressioning, then the use of creating some sort of virtual model and using computer aided design softwares to then go into manufacturing, whether it's in the initial phases of treatment, the provisional phases of treatment, the definitive phases of treatment. Digital data acquisition is key, right? And we have technological innovations that allow us to do that, right? Today, one of the most paramount initiatives that we have in our ecosystem is to get all of our offices, which is almost 1,000 offices today, we want to get all of our offices to the point of having an intraoral scanner and CBCT technology. One of our biggest initiatives. Why? Because if you collect data in the digital world on day one, everything else in the digital world becomes easy, efficient, predictable, allows us to diagnose with more relevance, more accuracy, allows us to execute on that plan, allows us to utilize technology to the fullest potential because we're starting in the digital world. So today we have a huge push, and it doesn't really matter. Look, I'm the implant guy, right? Everyone knows I'm the implant guy. I'm totally comfortable in my implant skin. But if you talk about endo, you talk about ortho, you talk about crown and bridge, you talk about digital dentures, you talk about any treatment modality we have today, orthodontic surgery, any treatment modality we have today, third molar extractions, anything that we talk about today, the use of technology and acquiring that data digitally is by far the best and most predictable way to chart a course. And so that's why we have such a big push to be able to do this. By the way, I forgot to mention at the beginning, any questions? Look, I'm so jazzed to be able to talk to you guys tonight. We've got almost 100 people. Any questions? Raise your no, don't raise your hand. You can raise your hand, we'll unmute you, but the easiest is the Q&A. Type your question in, let me answer. Let's have a dialogue, a conversation, because this will be a lot of fun if you ask your question right up front, okay? I'd love for it to be conversational. So if you've got any questions, ask them now. But we take intraoral scanning, we take CBCT imaging, and then we layer in software. And the software we layer in allows us to do amazing things. Like look at our 2D and 3D imaging, right? See our 2D radiography, take clinical photography, utilize all of this to digitally diagnose where we want to be and where we want to go, right? And then that way we're making really sound, accurate, relevant clinical decisions through software. And then we execute on that plan to create optimal restorations for our patients. It's all about this digital workflow. It's all about creating predictable outcomes for our patients. And by the way, giving them the best experiences possible. Because what world do 90% of our patients walk into our offices? What world do they live in today? They live in this world, the world of a smartphone, right? At the end of the day, they're used to having technological innovation be part of their life. And now when they walk into one of our Aspen offices, they see that their healthcare provider is as innovative as the rest of their life. And that's empowering. And that builds trust and confidence. And we want that, because then when we offer them the value of the treatments and services that we want to provide, patients say yes to treatment because they trust and they have confidence that we are able to deliver on what we talk about. So let's take a case like this. A patient comes in congenitally missing lateral incisors. We predictably go through a workflow where we digitally diagnose, we treatment plan, we acquire that data digitally. We start doing things like smile designs, right? Which isn't kind of a topic for tonight, but we do things like a smile design from a digital standpoint to be able to get a blueprint of where we want to go. And then we digitize that information and we use software to then plan the implants based on that smile design. So what you can see here is software that we use today in our ecosystem to be able to layer in where the existing teeth and tissues are, where the bone is, where the prosthetics are, and that allows us to make relevant clinical decisions. So you see here, you've got the bone, the CBCT. That's what you're looking at. Then you layer in the existing teeth and tissues, and the red is a prosthetic plan to tell me the ideal tooth position. Then I can do things like empirically measure 3 millimeters apical, 3 millimeters palatal from the proposed zenith of the free gingival margin. And now I know exactly where that implant needs to go. Not kind of, sort of, 100% empirically. We put the implant here, we're going to get the result we expect. And that's what we do today. And then we execute on that plan using some sort of innovation to allow us to put implants in where we plan them to be. Today, in my world, that means guidance. Okay. We're going to guide our implants through diagnosing in software and executing on that plan. Now, guidance can mean many things. It can mean static resin guide that's printed, soon to be printed in office, right? It's static resin guides that are outsourced if you don't want to print it in your office. It's dynamic camera-based navigation. There's even robotics on the table today in dentistry. There's a wealth and plethora of ways that we can execute on this plan. But the point is, we know that guidance works. The science shows us if you plan in software where an implant should go and you execute on that plan, you get implants within a couple of tenths of a millimeter of any bodily direction, apical coronally, buccolingually, mesodistally, and a couple of degrees of angulation. And that means you get accurate implant placement, like the congenitally missing lateral incisor case. And therefore, we're able to then build ideal restorations, which you see here. And then we use technology to recreate this in the definitive phase of therapy. And this is the patient 5-year follow-up, where we've recreated nature, teeth erupting from the gingiva that look like teeth, feel like teeth, function like teeth, and have a very happy patient in that process, right? And so we use this predictability time and time again to allow us to be able to offer relevant, predictable outcomes for our patients, right? Where we can take a patient who, again, has lost a tooth, in this case, traumatic fracture of tooth number 8. This was a basketball accident, elbow to the face, ended up 4 hours later in my chair. But we follow a similar pathway of digitally diagnosing, of making good empirical decisions based on software. Where's that proposed free gingival margin? How much does the implant need to be apically and palatally for us to assess and get the appropriate emergence profile? And able to recreate nature because of that, all through a digital workflow where we're able to replicate this time and time again as patients come in. And what I really love about the technology, what really excites me about the technology, is that this isn't some technology that I can use on just like a single tooth implant, or just for veneers, or just for dentures, or just for an aligner. This is technology that we can use, that we use in our offices every day for all modalities, including some of the most complex full arch edentulous cases that we're going to tackle with terminal dentition patients, with immediate load concepts, with really unbelievable predictability through the use of technology to take a patient who's going to lose their teeth, build a foundation like this, and then be able to replicate this in the final definitive phase of treatment. So here's a patient comes in. This lady, sweet lady, terminal dentition, number 8 was like class 6 plus mobility, right? Kind of moved when she talked, but she was so deathly afraid of losing her teeth that she just was kind of carrying on. And we talked to her about how we could predictably enhance her restoration. So that's exactly what we did. We digitized the information. And look at the ecosystem and the ability we have in our Aspen offices today. I can take a scan of where the existing crowns are. I can then take off those existing crowns and layer in scans of where underlying implants are. If you see here, this patient has some posterior implants. We're not only getting the tooth position, we're getting the emergence profiles, we're getting the implant position, all through our scanner that we have in our office today, right? Really tremendous amounts of data. So I can make really good clinical decisions, like make a screw retained prosthesis ahead of time that I know is going to engage those implants. So when she comes in and she loses those teeth, I've got confidence to tell her, you're going home with teeth that day, and they're going to look great. And that's what we did. We ultimately fabricated a screw retained provisional. We extracted the remaining dentition, and then we ultimately delivered a screw retained fixed provisional prosthesis all in one day. Now, what's exciting to me was this was only the second time I ever met the lady. The first time was me saying to her, hey, trust in us. We'll get this job done right for you. And she said yes. We took our scans, we took our photos, digital diagnosis, our CBCT, planned the case in software, made our provisional. Second time I see the lady, we're doing this type of restoration and work for her in the provisional phase. We let everything heal, integrate, and now we go to definitive phase of therapy. And look, we replicate that from the provisional phase to the definitive phase all through our workflow today. Using our intraoral scanning technology, we've got a wonderful partner in 3Shape today with the use of the Trio scanner, and we're able to do this in such unbelievably efficient ways where we can acquire all of this data and then be able to take that data to the manufacturer. Because remember, the data is accurate. I can see in one scan today where my underlying implants are. I can see where the tooth position is. I can see where the occlusion is. If I can do those three things, if I can see underlying tooth position, I can see underlying implants, and I can see the opposing dentition and how it all interacts, that's all the information my dental technician needs. And now I can tell them, take the case to finish. Now, mind you, this is the third real visit I've seen this patient, right? Visit one will change your life. Take some scans, acquire some data. Visit two, day of surgery, some post-op checks, make sure she's healing well. Visit three is what I call, used to be called final impression, right? Now today I call that our definitive data acquisition appointment. We acquire the data, we scan, we have all the relevant information. We give it to our lab technician and we say, make teeth. And that's what our technicians are able to do today, because now they have all of the relevant data files that they need. How can we deliver implant restorations before osseointegration has happened? So that's a great question. When you deliver a provisional restoration at the same time that you place the implants, it's what we call immediate load. We have good documented science today that's actually 20-year data, 25-year data today, that immediate load works for the full arch, meaning you're doing a full complement of teeth in one arch. When you follow certain protocols, you get good initial primary stability on the implants, at least 35 Newton centimeters of initial primary torque value, and you're rigidly splinting, cross arch stabilized, which means screw retained, significant thickness to be rigid. Brandon says, workflow for an all-on-4 fixed denture, would it be the same or would there be a further steps involved? No, what you saw was the all-on-4. The all-on-4 is this protocol of taking out teeth that are terminal or taking a edentulous patient. You place implants to get a good anterior-posterior spread or good distribution so that your restoration is fully implant supported. And sometimes, most times, it requires tilting an implant in the distal to get a good anterior-posterior spread. When you place the implants, if they go in with good initial primary stability, you've got good AP spread or good distribution and enough restorative space, you can rigidly splint the implants together, cross arch stabilized. And we know that the success of that today, 20, 25-year data, is as good as burying the implants. Unequivocally, statistically, if you asked me that question 10, 12, 15 years ago, we would have said it's possible, but it may be riskier. There may be more risk of an implant not integrating if you immediately load. Today, unequivocally, the literature supports, there's a plethora of scientific evidence to support that if you follow the protocol right, that doesn't mean you only have 10 Newton centimeters of initial stability. You've got your 35 plus, you've got cross arch stabilization, rigidly splinting. That means you can't use an overdenture with nylon attachments. You can't cement on a restoration because cement doesn't end up being rigid. If you screw, retain, rigidly splint the implants together, the success is as good as delayed load. What that means to us, what that means to me, is why would I want my patient to suffer through taking their teeth in and out for 6 months or 3 months or 4 months if I know that I can give them teeth that day? If everything works well, I can give them teeth that day and let them have a better experience. There's more value to the patient if we give them teeth that day. And therefore, if there's more value, patients say yes to treatment, which is why we do what we do. So at the end of the day, we follow this protocol through technology. We diagnose, we treatment plan, we offer, come up with a plan, we operate the plan, we do our definitive data acquisition, and this is what the patients see, the technicians see. They see teeth, they design it, and now we can create unbelievable restorations that are predictable, that are unbelievably easy for us to fabricate because all of the data is there digitally. We have a workflow today. And for me, this is so important because I I pride myself on being part of one of the greatest dental organizations in the world to innovate in patient care, to be able to say we treat patients in the best, most innovative ways possible. And that's a fact. That's a fact that I'm really super excited about because it allows us really to do amazing service for these patients. So you can see that we do this time and time again where we are able to take our patients, we're able to diagnose, treatment plan from the simple single tooth to the complex, the full arch, and be able to follow the same workflows to be able to offer really unbelievable therapeutic outcomes to our patients. And for you oral surgeons out there, let's take it a step further because we don't just do this for, the simple single tooth, the simple partially edentulous. We don't do this for what I consider today the simple full arch. We do this for even the most extreme cases. And what I mean by that are cases where we have to do something as important as zygomatic implant therapy. So a big push for us in 2021 is to get all of our oral surgeons trained on zygomatic implant placement because there's a need for it. There is the patient that has the severely atrophic maxilla that isn't a candidate for all on four because you can't get the AP spread. There's not enough available posterior bone. And yeah, we can tell the patient, we're going to do sinus lifts. It's going to take 6 months. We're going to put in implants. We're going to be waiting another 4 months. And a year from now, you're going to have teeth. Or I can say to the patient, my team, my surgeons, we're going to go in that day and we're going to put implants and we're going to plan it in software. Again, following the same protocols. You can see here in software where we plan where the implant's going to go. And then more importantly, we can operate to plan, right? We know where the implant wants to go, where it needs to go, and we're going to operate to plan and perform the surgery in that way. This is the classic case for me where we're going to use technology to allow us to get a good outcome with zygomatic therapy. For you oral surgeons that may not be as familiar with zygoma therapy to me is the fastest growing treatment modality in implant dentistry for the last 5 to 7 years. What's really happened in the last 7 years is we've realized that it's not just an academic exercise for the most atrophic maxilla where we're going to follow a path within the confines of the maxillary sinus and we're ultimately going to end up with an implant that's palatably placed to the point where it's not really a great outcome for the patient. Yeah, it's a set of teeth, but typically the framework, the bulk, the implant is all coming out in the middle of the palate because remember the maxilla, when it resorbs, it's atrophic, it resorbs up and in the posterior aspect, in is towards the palate. And when we were doing things purely within the confines of the sinus, we ended up with that unideal outcome for our patients. Well, about 7, 8 years ago now, we started going mainstream with the concept first espoused by people like Carlos Aparicio and Ruben Davo and Paulo Malo out of Europe, where we talked about the extramaxillary approach. And what that allows us to do is put the head of that zygoma in the right spot. And we plan that today. As you see here, we make a guide that allows us to place our zygomatic implant where the head of the implant is going to come out exactly where it's supposed to be from a prosthetically driven standpoint. And what we do is we put these implants in, we get great bone because the zygomatic process of the maxilla is tremendously dense. We get these nice, long, great implants in. We get the ability to immediately load them with a fixed full arch provisional. But look at the confines of the provisional. Look at the dimensions. When we're said and done, this is going to be teeth that look like teeth, feel like teeth, and function like teeth. And this is the definitive restoration. And this patient is one who's extremely happy because the teeth, the prosthesis, the restoration, it looks and feels natural. She feels like she has her teeth. And this to me is a great, tremendous benefit that we can offer in our offices because we obviously espouse and value the ability to use the digital workflow to get to this outcome. From something as simple as a single tooth, number 9, guy's playing basketball and he gets elbowed and breaks that tooth, to the most complex, this beautiful lady here has been told for 5 or 10 years she can't have implants. She has no option. She can't wear a denture. She's been gumming it. and her life has been decreased, the quality of her life, because she can't socialize. She's self-conscious. She doesn't like to go out in public. She doesn't like to go to the restaurants. She doesn't like to go out and meet friends because she's self-conscious about her teeth. And we were able to change her life and do it in a day, and do it with my team approach, with my oral surgeon, with my restorative doc, with the team around us. We planned it in software. We digitized the information on day one with our intraoral scanner, with our CBCT. We executed on the plan. We operated to plan by making a guide. The zygomatic implants, the head of the implants went in where they needed to go. And that's what we do guided with zygoma, which is create the osteotomy at the crestal portion of the maxilla. And then we followed those simple restorative steps using technology and intraoral scanning at the end in definitive phase to be able to give her this outcome in as little as 7 or 8 appointments, in as little as 4 or 5 months. What a life-changing treatment we're able to do. And that's why I get so jazzed about the A behind me, right? About being part of the Aspen Nation, is because we've embraced all of this. And again, yeah, I'm the implant guy, but we use the same innovations and bring the same passion, whether you're big on endo, whether you're big on ortho, whether you're big on dentures, crown and bridge, you name it, we want to innovate and we want to be at the front of that wave. I want to thank you all very much for taking the time tonight. I'm going to open it up. I left the last, 20, 25 minutes even for question and answer. So I really do appreciate everyone taking the time to be on tonight. If you've got any questions, I'm happy to talk about it. For those of you that need it, there's Melissa's contact information. Shoot her an email, shoot her a text, and she can give you my cell phone number. I'm happy to chat with any of you. Best way to always get a hold of me is, call or text, and we'll go from there. But thank you guys very much. I'll open it up to questions and answers.
That was so fantastic. I am ready to go back to school to be a dentist after that. That got me pumped.
I'm glad. It's
Yeah,
amazing. We're in a really unbelievably exciting time in dentistry. And people
it's
don't realize it because it's moving so fast. It's hard to keep up. But that's what I love about being part of our great organization, is the fact that we're riding the wave and we're at the front and we're innovating every day.
absolutely. Can you, oh, I see one of the comments in the chat. My only question is, how awesome and exciting is this? I love that. Absolutely love it. Um, Real quick, it doesn't look like we have too many questions, but can you just briefly just kind of touch on what the implant initiative kind of looks like for
Yeah,
Aspen as far as the new doctors coming in, the new
absolutely.
oral surgeons coming in?
So that's a great question, Melissa. So we made the commitment a couple of years ago now that we were going to make implants a very big part of what we do here at Aspen. To that end, we have developed a lifelong journey curriculum for you as you come into the Aspen ecosystem. As you become part of the Aspen Nation, you are immediately integrated into a curriculum of lifelong learning with dental implants. So if you come in and you've never even seen a picture of a dental implant, that's okay. We're going to teach you from the ground up. We'll teach you all about the fundamentals of diagnosing and restoring. We'll teach you all about the fundamentals of single tooth and overdenture concepts. And as you build your confidence as a restorative implantologist, we're going to take you on the journey to surgical placement of dental implants. And we'll get you comfortable and competent placing dental implants. And as you get to become a total solution provider of implant therapy, we're going to take you to the advanced concepts, the full arch concepts. If you're an oral surgeon and you come out with experience, or you join us and you've had experience, you've practiced for a while, whatever the case may be, we'll jumpstart you. We'll put you on the curriculum and the track and the career, wherever it is that your comfort level and your skill set is. If you're an oral surgeon, I want you learning. If you don't feel comfortable on day one, I want you as soon as possible placing zygomatic implants, because it's a tremendous benefit to our patients. It's a service really that we can offer patients. And so we've created a lifelong curriculum, starts on day one when you join, and you can take it as far as you want. We have the best innovation, the best resources, the best educators to be able to take that journey with you. And as much or as little of the implant of implant dentistry that you want to be, part of your skill set, we'll be a partner with you in that.
Awesome. Thank you.
Okay, we got some
Cool.
more questions
Yep.
here.
Go
I'll take
ahead.
them. All right, Dr. Omar, do we see integration of digitally printed models coming in soon at Aspen? Digitally printed models, yes. So if I think you're asking, is 3D printing going to be part of what we do? And the answer is yes. So for digital models, 3D printed models, for 3D printed dentures, for 3D printed aligners, snore guards, night guards, provisionals, probably definitive restorations at some point in the next few years, we are going to have 3D printing be part and parcel of what we do in our offices. Absolutely. It's not, sometime in the future. It's today. It's already in the offices, and it's only going to become more and more prevalent. Next question. For a new dentist at Aspen, when can we get implant training? So I'm glad you asked that. It starts the day you start. When you join us, you're enrolled in part 1 of our implant continuum. Day 1, part 1. You start with some online pre-learning. You go through part 1, part 2, and within your first 90 days, you spend a couple of days with me. It used to be in person. Right now it's virtual. It will get back to in person. You spend a couple of days with me learning about diagnosing and treatment planning, learning about restoring the simple dental implant therapies that are out there in our patient populations. And we have daily touch point. We have, communities for implants where you can post about your cases. I post cases. I post before and afters, products, tips and tricks. I post complications, right? Not all of them are mine. Some of them are other people's, right? And so we make implants part of your daily experience in Aspen on day 1. The minute you sign up, you're gonna have that experience. Next question. As in full digital denture process, meaning easier all-on-6 and all-on-4 procedures. So if you're talking about 3D printing in office, Dr. Omar, that we're doing that. Yes, absolutely. For any modality out there that if there's an application for 3D printing, we'll have the ability to do that. Our goal is to have 3D printing be part and parcel of how we offer therapy to our patients across any aspect of dentistry, because it is so useful today. Okay, Dr. Maggie, do Aspen Dental dentists pay for implant training? So what I would say is this: there are some parts of the implant continuum, most parts of the internal implant continuum, that absolutely is part of being, one of our Aspen doctors that you get enrolled in and you're going to get trained in. There will be certain external educational experiences that are going to become available to you as you go through your journey, and those obviously are not not all of them are covered. They would be something that the dentist would pay for, but again, it's as much or as little of the implant journey that you want to be a part of. Next question, Dr. Rawal.
You can read that. Go ahead.
That's okay. Dr. Rawal is so fly. Thank you very much. I look forward to working with you too. Brandon says, any thoughts or ideas where digitally dentistry or implants will be in the next 5 to 10 years? Brandon, that's a great question. I think what you're going to see is, because the technology allows us to be so predictable with what we're doing, I think you're going to see a real renaissance where implant dentistry becomes very everyday, and it becomes today, meaning a patient comes in and it could be a single tooth that's fractured. It could be terminal dentition, hasn't been to a dentist in 30 years. And you're going to be able to offer them comprehensive implant dental care today. We'll have the technology to be able to manufacture, to be able to plan, to be able to print, to be able to get them a life-changing opportunity every single day in easy protocols. And that's really exciting, because this is really, it's complex therapy, right? You're replacing a body part with titanium. It's not like an easy conceptual thing to do, and we're making it easy, and we're doing it in predictable ways that really impact patients' lives. I think you're going to see that. I believe truly in the next 5 to 10 years. Well, I actually really believe in probably the next 2 to 3 years, we will be the largest provider of dental implant therapy in the world. I think Aspen will as a company be the largest provider of dental implant therapy in the world. And that means we're going to be changing hundreds of thousands, if not millions of people's lives each and every year. And so that to me is just an unbelievable place to be. Okay. Last question. I missed the answer to the question on how implants get placed prior to osseointegration. So I think the question is how can you load implants prior to osseointegration? And the answer is immediate load or immediacy is a contemporary concept in dental implants that works. It has been around for 20 plus years. We have science that says if you follow certain protocols, good initial primary stability, good AP spread or distribution of implants, cross arch stabilized, rigidly splinted, those implants integrate as well, if not in some cases better, than delayed load or bearing the implants for 3 months or 6 months. So look, the science is there. I'm happy, again, you can always get my contact information. I'm happy to chat with you about it. The reality is immediacy works. Immediate load concepts work. And it's part and parcel of what we want to do to enhance the patient experience and give them the best outcomes in the best ways possible. All
So
right.
someone has their hand raised.
Sure.
I know sometimes people hit the button on accident, so I don't want to like, I don't want to just unmute this person and call them out. Actually, she just lowered her hand, so it
Okay.
probably was a mistake.
No problem.
Any other questions, guys? As Dr. Rawal said, you can always, shoot me an email. And also, when you registered, you received a confirmation email that has a link to a Google Sheet that I see. And you can utilize that even after we're done here. So if you have, certain questions and you don't, necessarily want to email me or whatever the case is, you can always put them in there. I check that daily. And if I see we have a lot of questions pertaining to what we spoke about today, I can always have, Dr. Rawal type something up to kind of, send out to everybody. Because chances are if you have the question, maybe someone else does too.
Absolutely.
We got one more.
Sure.
Are we able to view the implant lectures prior to starting?
So we do have some implant continuing education that is available. We have it through a couple of different mechanisms where we offer CE to everyone. I got to be honest. The best part of the implant continuum is the interaction. It's the immersion where we get to talk together. We get to go through concepts. We have dialogues, discussions, hands-on. Like it's very immersive and very much, I think, something that leads to a positive educational experience and allows you the confidence to go out and place implants. That obviously happens when you start with Aspen, but we certainly have some resources online. Absolutely. We're big believers in spreading knowledge and education to better everybody. So, and Melissa can certainly turn you on to some of those modalities that are out there.
Absolutely. Anything else, guys? All right. Looks like we're kind of quiet in the chat here. So thank you all for joining us. I know your days are long and busy and we appreciate you hopping on, and I hope that you all learned something. I know I did. As I said, I'm ready to go back to dental school now. So sign me up. Dr. Rawal, in all kidding aside, you are fantastic. I cannot thank you enough for doing this.
My pleasure.
And I told you before we started that if you did a really good job, I'd bother you to do this again. So we'll get a date on the calendar for next month, guys.
I am happy to do it anytime.
All right, awesome. Have a great night.
Thank you, guys. You all be safe, be healthy, and have a wonderful night. Take care.
Yep. Bye.